Thanks. Good morning. Thanks for having me speak here today. I have a three-part presentation, okay? And the first two parts are very quick, and those are hopefully a review for everyone. The first two parts are required mandatory information that is required for Danbury Hospital to be chest pain accredited. So these are going to be just a review of STEMI, non-STEMI, acute coronary syndrome, a couple of rhythm strips that need to be reviewed yearly. Big review, quick, we're going to kind of skim through it, okay? Then we're going to get to the meat of the lecture, which are a whole bunch of real live STEMI cases. Some are tricky, some are basic, but they're all meant to stump you, and they're all meant for you to be interactive, okay? So when we get to that part, it's just going to be yell out what you think it is. Is it a STEMI? Is it not? What kind of STEMI? Why? And that's going to be it all interactive, and that's going to be the meat of my lecture. So we'll start with just these two quickie review, hopefully for everyone. Chest pain accreditation, mandatory slides, okay? So starting with low-risk non-STEMI, ACS, and STEMI. Acute coronary syndrome is just an umbrella term, right? And it includes three different things: STEMI, non-STEMI, and unstable angina. Okay, so those are all under the umbrella, and we'll talk about those. Okay, starting with chest pain. So you know that there are a lot of different risk scores out there, and you'll start hearing different ones that the physicians are using now to quantify and qualify how serious patient chest pain is, what next diagnostic testing is necessary, should the patient go to the lab, should the patient have an outpatient test, outpatient stress test, or stress test while they're in the hospital, and they use all different types of scores. You may have heard of the TIMI score. The new one lately is called the GRACE score. These are just different things. You don't need to know how to calculate them necessarily, but just be aware that you're going to be hearing these new terms that doctors are using now to calculate risk scores for our cardiac patients. Okay, so patients that have chest pain, low-risk patients are patients who have angina, and they have a low-risk score according to the TIMI score, the risk assessment score. The next group of our patients are going to be the non-STEMI. They're still under the umbrella of the acute coronary syndrome, okay? These are your unstable angina, we use the term UA, or your non-ST elevation MI. Okay, or it also includes patients that are on the continuum, somewhere between the unstable and the non-STEMI, right? We've all taken care of those patients. One minute they have some chest pain, the next minute they don't. One minute their enzymes are negative, and the next minute they're positive. It's not just a straight cut, it's a continuum, so just be aware of that. And then everyone's familiar with this STEMI. That's our third category, and those are the patients that have true ST elevation on their 12-lead ECG. Okay. Everyone's pretty familiar with the signs and symptoms of acute coronary syndrome, right? Pressure-type chest pain, it can occur at rest or with exertion. It usually is going to last greater than 10 minutes. So those patients have kind of fleeting pain, not so sure if that's cardiac or not. So when you're asking your patients, how long did this last? When did it start? Those are the kind of information you need to get from your patients, okay? And, obviously your pain can radiate to your arms, your neck, your jaw. It can occur with or without radiation, but important to get that information. It can be associated with diaphoresis, dyspnea, nausea, vomiting, abdominal pain. Unexplained fatigue is a common complaint we hear. Syncope, right? That could be electrical or could be plumbing. New or increased exertional dyspnea. So that's an angina equivalent. Sometimes our patients don't have any chest pain, but they come in with this real exertional dyspnea. That can be an angina equivalent. We all know that gender plays a role, right, in different types of chest pain, and also older patients, greater than 75 years, and women particularly, majority still present with the typical symptoms, but many women and elderly present with atypical symptoms. Still the majority typically, but you need to know that a lot of women and elderly patients, and also other patients, especially diabetics, chronic kidney patients, and sometimes demented patients will have atypical symptoms as well. So you need to be aware of what those atypical signs are. Okay, factors that increase probability of a non-STEMI are going to be age, male sex increases your risk, family history, we all know that that's a real bad risk factor, right? History of coronary artery disease, history of arterial disease, vascular disease, diabetes, kidney problems. If you've had a prior MI or have had vascularization into your coronaries in the past, you have a higher risk of having a coronary event again. Makes sense. Atypical, these are those symptoms we want to be aware of. Everyone's really familiar with those typical ones, but atypically, like I said, diabetics, elderly, female, might present with some of these symptoms instead. Epigastric pain's a big one. Indigestion, stabbing pain. So this isn't your chest pressure that lasts for greater than 10 minutes. This is like someone saying, I just got stabbed in the chest. That's different, right? That's atypical. Pleuritic type pain, and then increased dyspnea in the absence of chest pain. That's a tricky one. Is that cardiac or not, right? That needs to be evaluated and investigated a little further. Okay, what's the pathophysiology of the acute coronary syndrome? Right, it's myocardial ischemia or infarction. It's usually due to an abrupt reduction on the coronary blood flow. Right, so what you have is the atherosclerosis, or your deposits of your lipids, your calcium, your fibrin, and they're inside the lining of the arteries. And think of it as a tube, right? And as that tube gets clogged, it gets narrower and narrower. That's what your inside of your coronaries are going to look like. Right, and this starts a progressive inflammatory response in the endothelium, and you end up with fibrous plaque. I'll show you a picture coming up. And the plaque itself inside that lumen of the artery is what can either potentially or totally occlude the whole lumen. Right, and the plaque, as we know, can be very unstable inside a lumen or inside a coronary artery, and it can break free. Plaque ruptures and breaks off, just like if a scab broke off your arm, right? It's going to bleed, it's going to cause platelets to aggravate to the scene, right? And they're going to cause a clot or a thrombus. That's what occludes your artery, right there, is your thrombus. Not necessarily your plaque breaking off, but the thrombus that forms subsequently. Okay? MIs can also be divided even further into type 1 and type 2. Type 1 being a spontaneous plaque rupture, and type 2 being a reduced myocardial oxygen supply and or increased demand. Here's our picture, right? You see on picture, well, this is first of all a picture of the LAD, so all the way to your left, you see the cross-section there of the LAD, and here are our pictures of our plaque. The first one, the plaque with the fibrous cap. The next one, the plaque ruptures, and then you see that the clot is forming, right, around the rupture, and that's actually what's blocking the artery, preventing the blood flow from continuing on through the lumen. That's the pathophysiology of acute coronary syndrome. So again, this is very similar to what we had before. Your top left, right, the lumen is wide open. You see on the top right, you're getting some atherosclerotic plaque, partially occluding the lumen. That plaque can be stable or unstable. Down the bottom, it's starting to get unstable. It's starting to disrupt. A little bit of thrombin is at the scene there, causing some unstable angina. These are the patients that have a little bit of plaque, a little bit of blocked arteries, and then they try to do something exertional, and they're going to get some exertional angina. But then once that plaque, or if that plaque breaks off, that's when we're going to get some non-ST segment elevation and the clot forming, and it can, as you see in the last two pictures, completely occluding, which would be a STEMI, or partially occluding, which would be our non-STEMI. Okay? All right, treatment, we all know we need to get that 12-lead EKG within 10 minutes of arrival. ER is really great with this. They have a very good system. Yes, they're doing EKGs. On the floors, not so well, right? Patient has chest pain, they got to call the resident, they may have to call the fellow, they're not sure which resident is taking care of the patient. Just get that EKG within 10 minutes. It's our guidelines. It's for chest pain accreditation, is that we do have this system in place. Okay? A STEMI, we all know, is 1 millimeter or more of ST elevation in 2 or more contiguous leads, right? Or a new left bundle branch block. Patient has these things on their EKG, they need emergent coronary angiography. Okay? Our non-STEMI, those are actually a little bit harder to identify, right? We've got to wait for those lab values to come back, because they're not going to have that obvious ST elevation on the EKG. So you do your labs, and if they have positive cardiac markers, that's when they say that they are non-STEMI. Okay? But they might show some ischemic-looking EKGs, which we know is T-wave inversions or some T-wave or ST depression. Those little subtle signs on the EKG while we wait for enzymes, and those are our non-STEMI patients. And then the cardiac biomarkers of necrosis are typically your troponin, and if it's elevated, you want to make sure you correlate that with the patient's clinical picture, because troponins can be elevated for a number of reasons, okay? But if they're associated with someone with crushing chest pain, then you've got to say that it's probably a cardiac event. Okay? Unstable angina can present without any objective data of myocardial ischemia. So in other words, patient has unstable angina when their cardiac markers are negative, their EKG looks essentially normal, but they're still having unstable angina. And it's probably because they had one of those pictures there with some minor plaque on it, but not completely occluding yet, except when they try to do something exertional. Okay, so this is just our algorithm, right? If patient has chest pain, we got to get that EKG within 10 minutes. And also, here's the thing, not only and we're good at this about getting the EKG, it has to actually be read by a physician within 10 minutes. So you gotta be running around with that EKG in your hands, find somebody to actually read it. That's what the goal is, and that's what the criteria is, okay? So not only done, but read within 10 minutes of chest pain onset. Okay, and then they have to decide whether it meets the criteria for STEMI, right? 1 millimeter or more of ST elevation and 2 or more contiguous leads. Okay, and if it does, we have a STEMI protocol in place, right? Everyone knows the number you call for a STEMI. What is that number? Everyone knows it off the top of their head, right? 7822, the STEMI line in the hospital for on hours. And then off hours, they still call 7822, and it goes to the operator. Okay, everyone should know that number, like a 55 number. If you're especially working in the units that you all do, you need to look at your EKG. If doctor reads it as a STEMI, 7822. Even if you're incorrect, even if you've overcalled it, we'd rather have it called. Okay, and we'll figure it out. Okay. If it's not a STEMI, then we have to do a couple more things, right? We've got to look at different EKG changes. What are they? Are they showing ischemia on the EKG but not STEMI? Does the patient have their symptoms? Are they typical symptoms or atypical? And they might consider medical management or further diagnostics. Okay. Patients that have a suspected acute coronary syndrome need to have rapid evaluation, right? Early estimation of their risks based on the likelihood of the acute coronary syndrome and adverse outcomes. And this is where we're going to use that TIMI score, that GRACE risk assessment tool. And that's our way of risk stratifying them to see, what we need to do next. If they're low risk, they have a low TIMI score or a low GRACE risk score. If they're intermediate or high risk, that'll help us guide treatment. These are just the two different scores. This is just the TIMI risk score. It takes into effect known CAD. Remember we said that was a high marker. Whether the patient's on aspirin, whether their cardiac markers are up, whether they have ST elevation, their age, and other risk factors such as hypertension, smoking, etc. And then you give the patient a score, and this is the percentage of risk of cardiac events in the next 14 days. That's what the TIMI score is about. Then we have the GRACE risk score. You're going to start hearing more about this. We've used TIMI scores for a long time, but GRACE is the new trend. And this takes into effect the KILIP class, which is like signs of clinical heart failure. So that's a different risk factor. Systolic blood pressure, ST elevation, whether they've had cardiac arrest, what their creatinine is on presentation, and their biomarkers and their heart rate. And then it gets calculated to low, medium, high, and it gives you a mortality of in-hospital and also 6-month mortality rate. So new types of scores. Let's talk a little bit about the biomarkers. I'm cruising through this because I really want to get to the STEMIs, okay? They're the most sensitive and specific biomarkers. They rise within a few hours. They remain elevated for several days. They can stay elevated up to 2 weeks if they have a large infarct. You're going to measure them right at presentation and then 3 to 6 hours later. The presence and the magnitude of troponin is useful for short and long-term prognosis. Remember, it's used for those risk factors, those risk scores. And troponin here in our hospital is less than 0.00. We say there's none detected, that's negative, or none detected. Treatment, right? For pharmacological treatment, what we might do for our patients, aspirin, everyone should be on antiplatelet aspirin. Nitrates, analgesics, oxygen therapy, right? We only want to use oxygen if their O2 is less than 90%. We used to pop oxygen on everybody. Now the American Heart Association guidelines are less than 90, you put them on O2. Okay? They should be on a P2Y12, which we have a couple on the market now. We have Plavix, Brilinta, and Prasugrel, in addition to 81 of aspirin. Okay? We have anticoagulants, heparin, bilvalirudin. Those are just 2 of them. We have several. All these patients should be on statins, beta blockers, calcium channel blockers, and perhaps ACE inhibitors if they have a low ejection fraction. So you, as nurses taking care of your patients on the floor, you notice they're not on a dual antiplatelet, or you notice that no one's ever started them on a statin or an ACE inhibitor, something you can bring to the attention of the cardiology team, right? Maybe that was a miss, they missed it. So we want to make sure our patients are getting on these drugs. Also, obviously, patient and family education is critical. What you teach them here in the hospital, they're only going to go home and use half of. So try to get as much information into them as you can. Acute coronary syndrome information, CAD, what is it, how does it build up, what are their risk factors, all those types of things. If they're going home on new medications, the purpose of the medicine, how long they should be taking it for, when and if they should stop it. Lifestyle changes, obviously we have a great cardiac rehab department here, and everyone should be getting into the cardiac rehab program and getting a consult from them. Talking about diet and activity, smoking cessation, there's no words, right? Cardiac rehab and cardiology follow-up. When are they supposed to see their cardiologist? Patients go home, they think everything's great, they got fixed in the hospital, 2 years later, we're like, did you follow up with the cardiologist? They got lost because they never followed up. No one told them they were supposed to follow up. They didn't get that information. Okay, I don't think we need to review this. Everyone's pretty familiar with how to do a 12-lead EKG. Like I said, this is mandatory information for the chest pain accreditation that we review this once a year. If you have any questions, see me after. Right-sided EKG, everyone should be familiar with how to do that. Just reverse your leads, right, and do them on the right side of the chest. This will give you a right-sided EKG. When do we do a right-sided EKG? Anytime we suspect maybe an inferior wall MI. There's no leads that go right over the right ventricle. So the only way you're going to see that on a 12-lead, you won't see it. So you have to do a right-sided 12-lead in order to get the leads right on the right ventricle and see whether you have some involvement of the right ventricle. So we typically will do a right-sided EKG for an inferior wall MI because they kind of go hand in hand with the RV infarct. Okay? Guidelines for stress testing. So, our low and our intermediate risk patients, we might be able to do their stress tests in-house, or we might have to send them out. It depends. We shouldn't be doing stress tests on patients unless they've had 12 to 24 hours of no pain. Okay, so we have to decide whether they can go home and have the stress test as an outpatient, or whether they should wait in the hospital and cool down a little bit and then have their stress test. Okay, it could be a treadmill exercise test, a pharmaceutical test, imaging modalities, right, echo, PET scan, depending on what they're looking at. And this can be done prior to discharge or after discharge. But we need to make sure there's some type of plan, right, before the patient goes home. So 7822, as I mentioned, is our STEMI alert numbers. We dial 55 for the operator off hours. Oh, so you don't dial 7822. That's only during hours, sorry. And then 55 after hours. And that will go to the operator, and they'll call in the team. Again, we would really, really rather that you overcall it. If your EKG is reading STEMI and you look at it and it doesn't look like a STEMI to you, just call it. We'd rather have our cardiologist look at it and determine that it was reading incorrectly, rather than miss it. Okay? An urgent cardiology consult is always a possibility. You can also call a fast team at any point if you're feeling overwhelmed, patient has chest pain, you got to get that EKG done, they need an IV. Just call a fast team, they can help you out. The multi-specialists are really great about filling out the STEMI sheets, etc. The hospital, I think we all know, anybody's got a cardiac event, 911. Okay, we're going to just go over a couple of rhythms in a moment. These are rhythms that are required to be reviewed once a year. I have a picture of each of them. I think they're pretty obvious. Okay, one other thing you may be hearing about, you might see signs in the community called EHAC, E-H-A-C. It stands for Early Heart Attack Care. There's a sign right outside the hospital. We are an EHAC center. So this is just a campaign to educate everyone on early symptoms of heart attack in order to prevent the heart attack from occurring in the first place, or from preventing it from causing further damage. To be responsible, not only for yourself, but for others in your community. Anybody who's got early heart attack symptoms, make sure that they obtain immediate treatment. We really want to encourage our patients never to drive themselves to the hospital with chest pain. Call 911, start the process. It shaves a lot of time off the STEMI times if a patient calls the ambulance rather than drives themselves, because the team could be here and ready and waiting for that patient on arrival if EMS was used. Okay. This is the EHAC survival, what's it called, ring. Okay. If they have any of these symptoms, and of course they could be overlapping, they may not have all of them: nausea, pain, jaw pain, fatigue, anxiety, chest pressure, squeezing or discomfort, maybe just back pain, shortness of breath, or just a fullness. Signs of potential cardiac, call 911. Don't chance it. Goals and the purpose of the chest pain center. So, Danbury Hospital is an accredited chest pain center. We'd like to keep it that way, which means that we have to have streamlined processes for the diagnosis, treatment, and management of patients who are low risk and who are non-STEMIs and who are STEMIs. So we have lots of processes in place, right, for these patients who present with these problems. And also we have to have a way to reduce admissions and ensure appropriate length of stay. We want to improve the patient engagement, leading to improved satisfaction scores. We want evidence-based medicine aligned with process improvement, and all our chest pain accreditation processes and algorithms all align with the latest ACC and AHA guidelines. If you have all these things in place, and believe me, they evaluate every second and everything you have, then you can be a chest pain center. So it's a big process. We want to make sure we keep this streamlined and everybody's on board with all of this. Okay, let me just show you those couple of rhythms that we have to review. Any questions on that part? I'm hoping that's a big review for most people. All right, I would ask you to guess what the rhythm is, but it's written right there. So what rhythm do you think it is? Okay, why is it SVT? It's narrow. What else? It's very fast, right? Those are two big criteria for SVT. Everyone should be able to recognize these major rhythms. What's a treatment for this rhythm? Adenosine. Okay, so medical treatments, 1. Cardiovert if they're unstable, 2. Okay. Everyone's well familiar with this rhythm, right? Okay. And everyone knows the drug of choice is adenosine. Okay. What's this rhythm? I don't know. Obviously, it's VT, right? Why is it VT? What's the characteristics of this rhythm? Wide complex, fast, and no P waves. It's pretty regular. Treatment for this rhythm. What's the first thing you want to do if you see this rhythm on your patient? Check a pulse. Good. Okay. And then what are we going to do? What's the treatment for a VT? Right, shock out of this. Okay. And also maybe some antiarrhythmics if they're very stable. Okay. All right. What's this rhythm? Torsade to point. What's the characteristic of this? What is this rhythm? It's a polymorphic VF, right? So, or VT, and everyone sees that, right? And what do we do for this rhythm? Shock, right? And carefully, okay? Everyone should be able to recognize these. These are our pretty basics. Everyone should know this rhythm. What do we do for this patient? Right away. Do we want to do CPR or should we shock? Shock. Okay, what about this one? It's a high-grade AV block, because it says so. Okay, what kinds of treatments do we need to do here? Put the patient on what type of? On a pacemaker, right. So, they're going to probably need a permanent pacemaker, but our initial intervention is going to be a temporary or an external at the bedside, right, until we can figure this out, right? This is going to progress to something worse. This is high-grade AV block. As opposed to third degree, right, complete heart block, this one's got to get to the cath lab a little quicker, right? They need a permanent pacemaker. Okay, everyone could recognize those basic rhythms? I think that was it. Oh, no, this one. Okay, what's the problem here? Right? No rhythm. What do you want to do for this patient? First thing, check a pulse. If they do not have a pulse, CPR. Okay, hard and fast, 100 a minute, deep compressions, right, until we can sort this out. And we can give antiarrhythmics, or what kind of drug is good for this one? Epi. Okay? So this isn't a review of ACLS, but these are some rhythms that everyone should be able to identify with their eyes closed. I think that's it. Okay. Questions on that part? This is all, like I said, just stuff we have to review yearly. I'm going to get into some STEMIs that are going to be tricky. Okay? All right. Let me see how I can get there. Okay, these were all real-life cases from an ER doc friend of mine up at University of Connecticut. Okay, so these are meant to stump you. These are also meant to be interactive, right? I can hardly hear you, so you have to yell. So I'm going to go through these and tell me what you think. Here's a 55-year-old man. He's got very concerning chest discomfort. What do you make of his EKG? before we go too much further, let's look at the setup of a 12-lead EKG, right? So I know I can't leave the post here, but as you can see, we have leads 1, 2, and 3, leads AVR, AVL, AVF, leads V1, V2, V3, V4, V5, V6. Those are your precordial or chest leads. And then across the bottom, we have a rhythm strip. Here it's lead 2. Sometimes it changes. Sometimes there's more than one rhythm strip across the bottom. So know what your orientation of your paper that you're looking at. Okay? So when we look at this EKG, tell me what you think is going on. This guy's 55, right? He's in that age range. He's a guy, and he's got chest pain. And what does he have on his EKG? Does he have ST elevation? Where? Okay, right? Everybody see that? Because we really can't go on unless everybody sees that, right? This is a straightforward, this is ST elevation, and in the leads, like you said, and that's the anterior septal region. We say this patient's having a big anterior septal MI. Is everybody with me on that, or else we can't go to some harder ones? Everybody can read a basic STEMI. Okay, onward. Okay, now, Mr. KB, he's 52 years old. He's a smoker, right? So risk factors, right? And he has a substernal chest pain, and it was 2 hours earlier. This is EKG number 1. He's in the ED. What do you think about this EKG? Does he have ST elevation? Let's start with that. Well, let's orient ourselves to the 12 lead, right? We have leads lead 1, 2, 3, lead AVR, AVL, AVF. V1, V2, V3, V4, V5, V6, and then across the bottom here, you see we have 3 rhythm strips. So make sure you know what you're looking at, okay? And they give you rhythm strips in V1, lead 2, and lead V5, okay? Pick one. All right, so what do you make of this EKG? Is this a STEMI? What's going on with the T waves? They're inverted or they're elevated, right? They're peaked. What causes peak T waves? Hyperkalemia. And so you can get hyperkalemia when the potassium's leaking out of their damaged cells. This guy's like leading into having something going on here. Okay, he's got peak T waves probably from some hyperkalemia. And also, we won't do that. Okay, next. All right, so this is now 3 hours later. He went for cath, right? He had angioplasty done. And now look at his EKG. What do you make of this? Oh, boy. Did they fix him? No. Okay, so they probably fixed everything, but he still has EKG changes, right? And this is common, especially in the ICU. When we bring our patients back after cath, they tend to sometimes have still some ST elevation. We don't fix all that each time. It will resolve, hopefully. Will continue to have this ST elevation right after their cath a couple hours later. Okay? So yeah, he's still got ST elevation. He's got Q waves now. Does anyone see Q waves? Especially like V2, V3. The Q wave's a downward deflection of the QRS, right? The first wave is going to be a downward deflection. That's a Q wave. What does a Q wave tell us? That he had an old event. Could have been hours, days, weeks ago. Now he's got Q waves developed, so we know he had something. Okay? All right, so back to the picture like we had in the slides before. We see that vulnerable plaque, right? Thin, vulnerable fibrous cap. You see that lipid core. And what's going to happen? That's going to break off. Blood clot thrombus is formed, blocking the complete lumen, right? That's another good picture of our occlusive thrombus formation, right? And that's what the platelets are supposed to do. They're supposed to go to the scene and cause a clot. That's what their job is. But when they do it inside the coronary artery, it's a problem, because that's now occluding it. Okay, how about this one? So this is a 35-year-old female. So not really in the age group or the sex that we really typically think, right? She's a TV producer. Big deal. Okay, so she has a family history of coronary artery disease. So she's got a risk factor there. Remember we said that family gene. Okay, 2 hours of chest pain and positive enzymes. So they took her to cath, and she has an occluded artery. Where is her MI? Does anybody know? The clue is going to be V1. So you see an inverted T wave there? That's not typical. So we took her to cath. Here is her, well, here's the question. Where's her MI? Is it anterior septal, lateral, inferior, or true posterior MI? How do we know? let me go back. It's actually, how do you go back? Okay, so it's hard, this one's hard, right? This is not straightforward. There's no straightforward ST elevation jumping off the paper, right? But this is a posterior MI. How do I know that? I see some ST depression in the anterior septal leads, V1, V2, V3, maybe a little V4, and those are specific, especially V1 having an inverted T wave. Those are telling me that there's some posterior damage. Again, hard to read on a 12 lead. Posterior MIs are rare, right? That you would just only damage the posterior part of the heart. Usually those are associated with a lateral or maybe an inferior posterior, but to have a straight posterior MI, it's unusual. Like only maybe 3% of MIs are straight posterior. But that's what this lady had. Very atypical, right? Very unusual. Okay, but she did have an MI, and she ruled in with enzymes. Something went on there, and she'll need to have like an echo and further testing to see how much damage there is to the posterior wall. Hard to see on a 12 lead, but it'll give you a clue when you see that ST depression over the anterior septal leads. Okay, how about this guy? 2 hours of substernal chest pain, and this was his EKG in the ED. See ST elevation? Or do we see any ST elevation? Start from beginning, lead 1. That's how I look at it. Start from the beginning, lead 1. STs are up. So when I see elevation in lead 1, I immediately go to the other leads in that group. So go to ABL. ST elevation? Yes. 2 leads in the same group with both have ST elevation. So I know already we have a STEMI here, right? 2 or more leads in the same group that have more than 1 millimeter of ST elevation. And leads 1 and AVL are which group of leads? Inferior, lateral, or anterior? Lateral, 1 and AVL. And the other leads in that group are V5, V6, which don't seem as affected. But we still have 2 leads in the same group. So this is a lateral MI. Okay. She also has some T-wave inversions, frequent, a lot of them, right? And she's got a lot of these deep T-waves. She's got this elevation in 1 in AVL. So this is a very ischemic-looking EKG. Okay. Would we bring this patient to the cath lab? Probably, yeah. Okay. All right, what about this one? So these are the type of EKGs you see in the ER that come in by ambulance. Yeah. Don't you like the ones with the computer printed out so nice and neat? All right, so what do you think of this? Even though it's hard to see, you can still see if something's not right in lead V2, V3. What is that? ST elevation. What do we call that? What area of the heart is that? Anterior. Yeah, so anterior wall MI. Yep. Okay. So this is call the cath team, have them prepared and ready before the patient arrives. Okay. How about this one? 74 years old. He's a man. He has epigastric discomfort and nausea. Not classic, but can be atypical, right? And what do you make of this EKG? Ask yourself first if he has ST elevation. Yes. Where? 2, 3 ABF. Are those all in the same group? What group is that? Inferior. We say he has an inferior wall MI. Okay. What else does he have on here to help me confirm that? So, sometimes if you have ST elevation or MI in one area of the heart, a mirror image of the heart is also going to have some other damages, like maybe ischemia. Ischemia shows up like what? T-wave inversions, maybe some peaked T's, ST depression. Do we have any reciprocal changes here? Yes. In what leads? Okay, so AVF. So that's on the opposite side of the heart, right? We know that he's got an inferior wall MI, and he's got like depression in 1. Look at the AVL. It's got the inverted T wave, pretty significant in 1 in AVL. He's also got, well, that would be the main thing. Okay, a little bit ST depression in, say, like V4, right? That ST line is not quite at baseline. So this is an ischemic-looking EKG, MI, and infarct and ischemia. Does this person go to the lab? Yes. Okay. Okay, 39 years old and a woman. She has sharp chest pain, and it's worse with inspiration, and it's worse if she leans forward. What do you make of that? Does it sound like a classic MI? No, but we shouldn't rule that out. Does she have ST elevation? That's your next question. Not really. Does she have an ischemic looking EKG? ST depressions, inverted T waves? Not really. But what do we notice? Look particularly at the PR interval. It's diffusely depressed. See the PR? Almost in every lead, it's very depressed. It's a little below the baseline. Shouldn't look like that. Should be very even. You see it very good in lead 2, right? Depressed PR. Okay. And then in AVR, we have an elevated PR interval. Both of those are signs of pericarditis. Okay. And she does look at the classic symptoms she has. Sharp chest pain, right? Very sharp. That's painful, that pericarditis, right? And always pericarditis is worse with inspiration, and it's worse when you bring your heart to the chest wall. Worse, right? Pleuritic type pain. If you press on their chest, it hurts. So this is a very classic example of the story and the EKG pericarditis, not a STEMI, right? Does everybody see that? Okay, 50 years old, history of gallbladder problems. Come in with the right upper quadrant pain, but it slightly radiates into the chest, just to throw you off. Okay, what do you make of this? Is she having a STEMI? Very hard to say. Why is it hard to say? What does she have on her EKG? Bundle branch block. Right, everybody sees that wide QRS. Very hard to diagnose a STEMI when you have a bundle branch block. It just masks it. It just covers it. You can't see the ST elevation. Okay, so you really can't say and diagnose a true STEMI with a bundle branch block. So what do I need to do? I need to look at her old EKG and see if this bundle branch block is old, she's always had it, or it's brand new. Then I'm more concerned. Okay, because if it's brand new, maybe he or she is having a cardiac event. Okay, but I just can't see it. But if it's old and she's had this bundle branch block before, I'm not that concerned. Okay? But you also notice that she has Q waves, inferior, anterior, and the septal leads, which suggests to me that maybe she's had cardiac event or MI in the past. Okay, so this one needs a little more investigating. Okay? All right, how about 87 years old, an active woman who has cardiomyopathy, and she presents with very atypical chest pain. So is there an anterior ST elevation on this EKG? Who said that? Can't tell she's paced. Perfect. Can't tell. And not only is she paced, she also has a bundle branch block. Masking. This isn't something that we're going to be able to tell first glance. So she's got a bundle branch and paced rhythm, both of which are going to mask an MI. Very difficult to read this EKG. One clue that we can have is that she has, just difficult to say. We can't say because of the paced rhythm. All right, so this one you can't read right off the top of your head. You need to call Dr. Wasserman. Okay, 76 years old. This is a male. Has a history of acute renal failure, right? A very atypical type chest pain. Why are the T waves peaked in V2 through V5? Is this an MI? You see those peak T waves? We saw that earlier. This is a renal patient. What do you think? Hyperkalemia. Do you think it's an MI, or do you think it's just all from hyperkalemia? Well, we can check a K, and we did, and it was 6.9. Okay, pretty classic, right? You've got that patient who with a history of renal, and this diffuse, it's not like the T waves are peaked in one area. Diffuse peaked T waves. We call this, obviously, those are T waves, hopefully from hyperkalemia and nothing else. So we'll rule that out first. Okay, does everyone see that? Okay. All right, here's a 64-year-old guy. He's got chest pain. It came on suddenly. It's very substernal, right? And this is his EKG. Is he having an MI? He is. Okay, who said he is? Why? And what kind of an MI? All right, where's the ST elevation? Start with that. Start from the beginning. Lead 1, elevated. A little. Go to the other leads in that group. AVL? Maybe. What else is in that group? 1 AVL, V5 and V6. Those are all your lateral leads. Are those elevated? Significantly so. And so lateral for sure. Sometimes lateral doesn't stand alone. It kind of attaches to another wall, like the inferior and the anterior. So look at those. How about the inferior? Are those elevated? Those would be leads what? Good. Are those elevated? Not so much. How about the anterior leads? Oh yeah. So we call this an anterior lateral MI. Does everybody see that? Elevation in V1, V2, V3, V4, V5, V6. And a little in 1 in AVL. Big MI. So it's not how tall the ST segments are that make it a big MI. Right? You see all these ST segments that are 5, 6 millimeters, like, whoa. It's not that. It's how many leads are involved. That makes it a bigger MI. Because the more leads involved, the more wall that's affected. Okay? So don't get so excited when the STs are so high, you think, oh my God, it's how many leads? He's got a lot of leads involved, which means there's a lot of territory being affected. Okay? So this is a big anterior lateral MI. 24 years old. Not so much in our typical age group. Can't rule it out. It's a male. He's got chest pain. What do you make this? How about if I said he's African American? Does that help? Not so much. Does he have ST elevation? What does he? So this isn't really ST elevation. It's another tricky one. This is J-point elevation. The common in young African American males. And it's not aesthetic. Right? J-point elevation, the J-point is your juncture point between your QRS and your ST segment. That point right there. It's elevated. You can see that. But this isn't your typical ST elevation. This is just J-point elevation. Just that juncture point is elevated. Not ST elevation segment. Okay, he's 24 and he's African American. Call this J-point elevation. You need to correlate this clinically with the symptoms and what else is going on, etc. Does he get rushed to the lab? No. Okay. These aren't straightforward. Now this, yes. Right? So yeah, I mean, you have to correlate that clinically. What's that chest pain like? Is it cardiac pain? You know, say he didn't have any chest pain, we say this is totally just J-point elevation, but he has chest pain with it. Definitely requires some further investigation. Yeah. This you guys have probably seen in the ICU, right? These are our neurogenic T waves. This is bad sign, right? Bad subarachnoid deep, inverted deep, wide T waves. Called neurogenic T waves from subarachnoid. You guys all seen this in ICU at some point in your career? Yep. Okay. How about this guy? He came in on April Fool's Day. He's 35 years old. He's Asian. He smokes. He has sharp chest pain, and it's worse every time he coughs. Let's go to the cath lab. So similar to our guy before, look at his J-point. So that's J-point elevation, not ST elevation. So this needs to be clinically correlated with the symptoms. Get cardiology involved. It's not a straightforward STEMI. Doesn't get rushed to the lab. So these are tricky, right? Look at that, you go, right? troponin, should we bring her to the lab right away? What do you make of this EKG? What do you see? Do you see ST elevation? V2, V3, yeah, maybe a little V4. So that's what, anterior area? Okay, so let's correlate clinically. She's having some chest pain, but she doesn't have any risk factors, right? But she's having chest pain, and she has an EKG that looks like this. We're obligated to bring her to the lab to see what's going on. Okay? So we bring her to the lab, and let's say also, since we sent that troponin, let's say it comes back positive. She's going to the lab anyway. Here's her EKG, angiogram. Takotsubo. Has everyone seen this? Okay. It occurs, for some reason, in this area of Danbury, Connecticut, we have a higher incidence than anywhere in the world. High incidence of Takotsubo, especially at Danbury. Everyone can see this. This is a stress-induced cardiomyopathy, right? We said she had a very stressful job. It mimics coronary disease. You have to bring these patients to the cath lab and rule this out. You can't just assume. You have to take them there and look at the arteries. So her arteries in this EKG, in this coronary angiogram, were clean as a whistle. Stress-induced cardiomyopathy. You see the apex is like ballooned, right? It's also called the broken heart syndrome. How many times have we seen a spouse after 60 years of marriage, and then the other one passes and the next one has chest pain with Takotsubo cardiomyopathy, right? So broken heart syndrome, typical for stress, more common in women. Left ventricular dysfunction is precipitated by an emotional acute distress. And it was named in Japan after the shape of the octopus paw. So that was the shape of the octopus paw to catch the octopus. Once they go in, they can't get back out of the tight narrowing of the top. So this is Takotsubo's. We see this a lot. We do take these patients to the lab, and we have to make sure they have clean coronaries. Okay? All right, how about this one? 32-year-old sportscaster. Typical substernal chest pain. He was playing basketball, so he's stressing his heart. He's young. What's he got going on here? Ask yourself, does he have ST elevation? Yes. In what leads? That's your next question. 2, 3, and AVF. Are those all in the same group? What group is that? Next question. Inferior wall, that's correct. What artery is that associated with? Right coronary. Okay, good. Inferior wall, MI correlates to the right coronary. Okay, but what else does he have? Is that just all alone? What's that lateral wall doing? Remember, it doesn't stand alone. It hooks on. Okay, so we've got a lateral involvement too. So this is inferior lateral MI. Okay, and how can we confirm that? What's the anterior leads doing? What kind of mirror or reciprocal changes do we see anteriorly? Right, inversions, ST depression, those are signs of ischemia. So yeah, you've got a big MI in the inferior lateral region, but you have ischemia in the anterior region. So like the infarct is not getting any blood at all, and the other vessels are like barely getting blood, and they're ischemic, and they're crying for oxygen. So you've got a couple things going on here, and this is a big MI. Why do I say it's a big MI? Because the STs are tall? No, because it involves a big region. Okay, does everybody see that one? Okay, this is the Sunday night special. Okay, so, a white male, 68 years old. He has severe chest pain. He has shortness of breath. And then all of a sudden, he becomes hypotensive, and you hear a loud murmur. He goes into cardiogenic shock. I hate that. Okay, what do you make of this? What do you think caused this? This was his EKG right before he goes bad. Does he have any MI? Does he have ST elevation?
Yeah.
Where?
Inferior.
In what leads? Maybe AVF, definitely 3. But what does he have more significantly? A lot of ischemia. Does everyone see that? Those inverted T waves, the depression of the ST segment throughout? Very deep. This is ugly. Very ugly EKG. Okay? And what happens when he goes hypotensive, goes into shock, and you hear a loud murmur? He probably ruptured a papillary muscle. Hate that. Okay? He goes into shock, all of a sudden he's got a murmur he didn't have 5 minutes ago, and he's now, hypotensive and in shock. So you got this EKG just in time. Okay. But that's ugly. Okay, 38 years old, has some kind of a heart problem, doesn't know what, and they're en route to the ER, but they're coming in for a leg injury. No chest pain. Someone did an EKG. What's up with this EKG? Is he having an MI? Is he having an MI? Does he have ST elevation? Is he having a STEMI?
No.
Does he have an ischemic looking EKG?
Yes.
Why? Because he has ST depression and inverted T waves. Okay. What else do you notice about his PR?
Short.
Very short, and can you see, or can we see it well? Can you see delta waves here? Delta waves are like the QRS is curved and slurred on the way up. It's a short PR with a curved, I think you can see it in lead 1, V1, V4 maybe a little bit. So when you have this slurred, and we call it a delta wave, associated with a short PR, this is probably a conduction abnormality. It turns out his heart problem that he had a long time ago was WPW. Okay, so that's what his problem is. Is this an MI? No. He's got WPW, electrical problem, right? A circuit problem. Oh, you can see it good in V3. You see that slurring of the QRS? Well, it's hard to see. So that's what this is going on here. All right, almost done. Previously healthy, 38-year-old APRN, she has palpitations. Is this somebody's EKG? Okay, and because we live in Connecticut, it's pretty obvious. She spends a lot of time with her family in a beach home in East Lyme. Okay, what do you think's going on here? Is she having an MI? Does she have ST elevation?
Yeah.
Not so much. Does she have an ischemic looking EKG? No. Okay. So look at the rhythm strip. Is the rhythm regular or irregular? It's a heart block. Due to what? Lyme. She lives in East Lyme, right? She lives in East Lyme. She has an irregular heart rhythm, which when you look harder, it is a heart block. Right? This will resolve if you get her antibiotics for a few weeks. This should go back to normal. That's why we don't put pacemakers in people when they have Lyme. We wait to, see if it resolves after some antibiotic treatment. We do see this a lot living in our area. We don't rush these people to the lab. Okay, 80 years old. He's got abdominal pain, but of course it radiates into the chest. And does he have a lateral MI? Big tip-off here is going to be lead 1. Does it look different to you? Who said that? Yes, the leads are reversed. And we know that for a number of reasons, but particularly I always know it if inverted P wave in lead 1 should never be upside down like that. So there's lead reversal. Okay? So before we can say what's going on with this EKG, we really need to do it properly. Fix it. Fix the leads. Okay? Because, yeah, it's got some inverted T waves and stuff, but I don't know if those are true until we get the leads on right. Okay? All right, okay. So now we have 2 EKGs of the same person, pre- and post-angioplasty. Okay, the first one, the patient woke up, 2 o'clock in the morning, severe chest pain. EKG was sent by EMS to the ER. The cath lab was waiting for the patient when she arrived. That's how it should happen. Okay, and what do you make of that EKG on the top? Inferior wall. Why do you say that? Because you see ST elevation where? 2-3 AVF. Inferior leads, what vessel do we think might be involved? Right. Do we see some reciprocal changes or some other ischemia on her EKG? Maybe. Okay. And then 2 hours later, after she goes to angioplasty, now she's in the ICU, and this is her 5:14 a.m. EKG. And is it better?
Yeah.
All better? Pretty much. Does she have any Q waves? Yes, she does. Surprisingly, in the inferior leads. Right? And those are there now because she's had an old MI. Even just a few hours later, she's got Q waves, and they'll be with her forever. Okay, does everyone see that? As opposed to one of our earlier EKGs where we sent the patient to the ICU after the STEMI and the elevation was not resolved yet. This one, they're all resolved. So sometimes it does, sometimes it doesn't. Okay? So you can see that's pretty straightforward. A few more. 70 years old, he's got chest pain and abdominal pain. Is he having an MI? Where?
Inferior.
Okay, what else does he have inferiorly? What does he have in those inferior leads besides elevation? What is it? Can't hear you. Q waves. Right, so what does that mean? Old MI. So this is a really classic example of something where I have to get the old EKG and compare. Did he have those Q waves, or is this new? Okay. Is this an MI that's evolving right now, or did he have that? Something you got to look closely at for this one. Should he go to the lab? Probably, anyway. Okay, 49 years old. He's got hypertension. He came in with chest pain and marked hypotension. Hint, this is not VT, it's sinus tachycardia. Is he having an MI? The STs are up all over. It's ugly. Right? When we see ST elevation in AVR, that's significant. He does have that. We usually do not see that, right? AVR is not really in any of the groups. So when you do see it, it's a red flag. The fact that he's very hypotensive, saying something bad's going on, okay? This is probably indicative of either left main disease or a dissection. Okay, when you see that AVR elevation, red flag. Okay? All right, so let's look at the bottom EKG. This was the earlier one. Marked ST elevation in the setting of a right bundle branch block. It looks a lot like VT. Hard to diagnose it. Hard to say whether it's an MI. The bundle branch block's blocking my view. Okay, so then later on, they get another EKG, and the bundle branch block is still there, but the ST elevations have resolved. So should they go to the lab to see what's going on? Probably, yeah. Okay. 70 years old. He's got epigastric abdominal discomfort. Is there a STEMI? Does he have ST elevation? Where? Inferior wall. Do you see anything else? Where? Okay, so where's his MI? Should we forget about it? There's no MI? Call the stomach doctors for his abdominal pain? Does he have an anterior septal MI? Lateral? Inferior, posterior? Enough is enough. Bring on Dr. Wasserman. Which one? Want to see it again? You already said inferior. What goes with inferior sometimes? How do we know if it's posterior? Could be like some anterior ST depression. along with an inferior wall, tells me there may be some posterior damage as well. Does he have that? Yeah. It's an inferior posterior MI. So what's the answer here? And what else? D and E. Okay. I'm doing both. Thank you. Any questions? Questions on the chest pain accreditation stuff? Questions on the EKGs that we saw? Some were straightforward, some were not.
I'm noticing that patients come through now, a lot of troponins.
Positive troponins?
No, any troponins.
Any troponins? Oh, meaning not being done?
Yeah.
Yeah. Okay, we should still be getting them. The troponins will be falsely elevated. If the patient, say in your situation, comes through the ER, has a STEMI and goes right to the lab and then right to the ICU, the troponins are going to be falsely elevated from the manipulation. But we should still be getting CK, CKMB. And people should still be getting troponins, just a trend, the downward trend. So they should be getting done. But I do see them troponins are getting pushed away, especially in that situation, because it's not going to help them do anything because it's going to be positive. To see the next one, that's coming down. But it's getting missed. The CK in that situation is a little bit better, because that's going to be more sensitive than troponin, which is going to be positive if you sneeze. Yes?
Asking for a uniform doing our EKGs.
And how you do them, or?
Where we place them. So
Oh.
people place them all the way down by the wrist, and then we tell them, so there's different,
So everyone's getting the chest leads correct?
the chest lead.
Okay. So then the limb leads, they don't have to go anywhere specific. They do have to go in the 4 limbs. But, usually they don't have to go anywhere specific. It's going to be the same, as long as they're not over bony area. That you have in a good spot. There's no specific rule on where it has to go exactly. As long as it's on the 4 limbs. So it doesn't matter if it's here or here, as long as it's on the limb. But the chest leads have to be perfect.
Because that's the debate. Some people saying five.
It doesn't really matter.
That's good.
Yeah, that doesn't matter. The limb leads just have to be on the limbs. Any other questions? Was it helpful? Is it a review? Okay.